This podcast is intended as healthcare practitioner education only and is not a substitute for medical advice, diagnosis, or treatment.
Ischemic heart disease is a condition in which the arteries of the heart are gradually blocked through atherosclerotic disease, and this can lead to long-term complications such as heart attacks, and also something called angina, which just means that someone experiences chest pain regularly, particularly when exercising. But it can also cause other things such as heart failure.
And more we're realizing that the process of atherosclerosis, or how our body starts to lay the foundations of atherosclerosis, occurs in the first 2 decades of life, often teenage years.
You look at the risk factors for cardiovascular disease and Alzheimer's, huge overlap. Diabetes is the major one. One of the few genetic risk factors is ApoE4, which is both involved in atherosclerosis and in Alzheimer's.
This is Bioconcepts Between Clinical Minds, the podcast that's open-minded enough to take in all sides of a clinical story. You'll hear from researchers, doctors, naturopaths, nutritionists, and patients. We look at common clinical presentations through a different lens. It's open, frank, and sometimes controversial. Nothing is off limits. Will it change the way you treat? We'll leave that up to you. In Season 2 of Bioconcepts Between Clinical Minds, we look at cardiometabolic health. We talk to experts in the field who will take you into their clinics and share their experience. I'm Tony Chambers, and this is Bioconcepts Between Clinical Minds. In this episode of Between Clinical Minds, we discuss ischemic heart disease with integrative cardiologist Dr Jason Kaplan and specialist GP Dr Sandeep Gupta. And related to that, Dr Michael Osiecki discusses dementia. Dr Sandeep Gupta is an integrative GP with a special interest in cardiometabolic conditions.
Ischemic heart disease is a condition in which the arteries of the heart are gradually blocked through atherosclerotic disease, and this can lead to long-term complications such as heart attacks, and also something called angina, which just means that someone experiences chest pain regularly, particularly when exercising. But it can also cause other things such as heart failure. And there is an incidence of what we call arrhythmias, which is abnormal heart beats that can occur in ischemic heart disease, particularly if one of the areas of the heart that's responsible for creating the electrical signal is affected. And there, unfortunately, is also a certain rate of sudden death that goes along with ischemic heart disease. So it is a very, very important condition and very deadly.
So atherosclerosis is the main cause. So can you just describe that process of atherosclerosis?
Atherosclerosis is the process of the arteries of the heart gradually becoming blocked. And in fact, it used to be, or originally the hypothesis was that the arteries slowly just become more and more blocked through the buildup of cholesterol and plaque on the arteries. And one develops angina if the blockage goes above a certain severity. And then if it goes to 100%, you get a heart attack. Now, it's actually now known that it's much more complicated than that. And it's not really just a slow buildup of cholesterol, but it's to do with what we call endothelial dysfunction, which means it's to do with the inner layer of the arteries or the blood vessels of the heart becoming damaged. And so what happens is people who have heart attacks may not necessarily have very high level blockages. It can be that someone, for instance, only has a 10% blockage, but because there's a lot of inflammation in that particular lesion, it attracts clot to it as a repair mechanism, and then that causes a heart attack. So it's not so much that it's just a gradual buildup of cholesterol through the arteries, but it's actually an inflammatory condition in which the endothelium or lining of the arteries is damaged, and therefore cholesterol plaque and also clots are attracted, which can cause various complications.
And can you discuss the traditionally thought driving factors behind the development of atherosclerosis?
There's four really common traditional ones, or let's say five, and they are firstly high blood pressure or hypertension. So it's thought that if you have high blood pressure throughout your life, then that creates a strain on the coronary arteries, which makes it much more likely to develop ischemic heart disease. Secondly, high cholesterol, and particularly elevation of the LDL cholesterol is thought to be particularly harmful for the heart. We'll go into this a little bit further, but I'm just going to give you the traditional view. There's also another pattern which is also thought to be important, which is where you've got a low HDL cholesterol and a high triglycerides, and that's sometimes referred to as type 2 hypercholesterolemia. That's also thought to have a minor role. Now, thirdly, diabetes. So either type 1 or type 2 diabetes on an ongoing basis appears to damage the arteries of the heart and make it much more likely to get coronary artery disease. Fourthly, a positive family history for coronary artery disease. So if you've got a first degree relative, which means mother or father or a sibling who has had an infarct, which is the fancy way of saying a heart attack, before the age of 60, then that is considered to be a very strong risk factor. And I guess that points to genetic factors. The number 5 was a past history of cigarette smoking. So I think that's quite undisputed. If there's and we often measure that in terms of pack years. So let's say someone smoked 1 pack a day for 10 years, that's a 10 pack year history. And generally anywhere above 10 pack years is very significant in terms of increasing your risk.
Dr Jason Kaplan is a specialist adult cardiologist and physician with a special interest in integrative and preventative cardiology, and says the process of atherosclerosis starts at a scarily young age.
More and more we're realizing that the process of atherosclerosis, or how our body starts to lay the foundations of atherosclerosis, occurs in the first 2 decades of life, and often teenage years. We've done autopsies on young men that were involved in the Korean War and the Vietnam War, and we've shown fibrofatty plaque in their arteries. But you're right, it is a gradual build-up related to multiples of different risk factors. One of them is genetics and family history. The other is certain genetic conditions of cholesterol, where people have very high cholesterol, but long-standing high cholesterol. Other concerns such as diabetes, high blood pressure, poor dietary choices, lack of exercise. And more we're realizing that inflammation plays a part in atherosclerosis as well. So all of these factors in one individual may then contribute to the development of atherosclerosis in someone's coronary arteries.
And what are your thoughts on, we've heard like the risk factors or the driving factors that you just mentioned. One of those, I suppose, that you didn't mention was that we often hear is saturated fats driving atherosclerosis and ischemic heart disease. What are your thoughts on that?
The one that I didn't mention as well, Tony, was lack of physical exercise. So it's very well shown people who do not a lot of physical exercise, are also at risk. But saturated fats do play a part. Saturated fats drive up serum LDL-C and more atherogenic lipoproteins, such as ApoB. And ApoB is a marker we're going to be seeing used more and more. And ApoB is a sum of all the atherogenic lipoproteins in our bloodstream. Now, if we know that atherosclerosis has its origins very early in life, in the first few decades, and one of those risk factors is higher LDL-C levels or ApoB levels, then it would seem that the best thing that we can do is try and maintain low levels in the first few decades of our life. And saturated fats drive up these, especially in certain susceptible individuals. the dietary patterns that have been shown to be most beneficial at preventing cardiovascular events, none of them have a high amount of saturated fats in their diet, and they often replace them with polyunsaturated and monounsaturated fats.
What are your thoughts on cholesterol and LDL-C, often termed bad cholesterol? What do you think about that term bad cholesterol? Is that the way that you kind of term it yourself when you're talking to patients?
Look, I tend to not use the word bad cholesterol, but I like to think about the term more plaque-forming cholesterol. And we're actually getting a little bit better at defining, someone's risk by looking at their cholesterol profile. So I don't just talk about LDL. That's why I think a marker such as, ApoB is useful, because it's the sum of all atherogenic lipoproteins. And also more and more, we're looking at a new marker called lipoprotein little a. Lipoprotein little a is often elevated in people who have early atherosclerosis, early ischemic heart disease. And to summarize it, lipoprotein little a attaches itself to certain lipoproteins and cholesterol particles and makes them more likely to deposit in the arterial wall. So it's not just about the LDL. In some patients, what I will also do is I will do something called LDL subfractions, where we can differentiate between the small, dense LDL particles. These are often more likely to deposit in the arterial wall versus more the light and fluffy LDL particles, which are less likely to deposit in the arterial wall. And then we create a picture for the person sitting in front of us. It's often too simplistic just to attribute it to one factor. But what I do want to say is, if you do have risk factors, and if there is early atherosclerosis in your arteries, as measured by the testing such as a coronary calcium score or an ultrasound of your carotid arteries, we do know that achieving a lower LDL-C can help reverse that process and lead to a situation where no new plaque formation will be laid down. We've shown that very elegantly in multiple both primary and secondary prevention studies. In fact, we were able to show that if we bring the LDL-C under 1.8 millimoles per litre, we can perhaps even reverse the volume of plaques. And this is detected on an amazing test where we can actually put an ultrasound in someone's coronary arteries, and we can actually see the reduction in plaque volume. And this occurs when the LDL is under 1.8. The other really important thing I'd like to emphasize about LDL-C is we know that populations around the world that have a lower LDL-C do not have a clinically significant burden of atherosclerosis. And in 2017, published in The Lancet, there was a cross-sectional study done of the Chimani people, which are hunter-gatherer people living at the edge of the Amazon in Bolivia. And they have the lowest rate of coronary atherosclerosis compared to anyone in the world. In fact, their arterial age is 28 years younger than when compared to the average person in Western society. And they do this by having a hunter-gatherer lifestyle. Mostly the diet is lower in saturated fats. Their average LDL-C lies at around 2.335, and they definitely get lots of exercise a day. They're moving all day, and they have the lowest rate of atherosclerosis out of any population in the world.
That's very interesting. I just want to pull out a point that you were talking about before and just explore a little bit more about the coronary artery calcium score. So can you explain that a little bit more, please?
Great. So the coronary artery calcium score has been around 20, 25 years, but it is a simple, non-invasive tool. And what happens is people go to radiology practice and have a non-contrast CT scan of their heart, and it quantifies the amount of long-term atherosclerosis that is there in the coronary arteries, and that is depicted as calcium on the CT scanner. This is scored according to a standard algorithm that is used internationally and universally called the Agatston score, which was named after Arthur Agatston, who was a cardiologist in Florida. And then not only do we know what the score, if there's the presence of atherosclerosis, which is really important, the younger people are, but also we can compare you to other age and sex-matched cohorts and other other ethnic backgrounds, integrating that information from a study called the multi-ethnic study of atherosclerosis. And we also know by studying and following up people with elevated calcium scores, we have a very clear idea about what their risks are of developing clinically significant complications related to ischemic heart disease. And we know what interventions will work best in some of these populations. So it is a simple, non-invasive test that can be used in men around the age of 40, in women closer to the age of 50, have a marker of what is going. Do you have the presence of atherosclerosis? Is it higher than expected for someone of your age? And then the next question is, well, if there is atherosclerosis there, then what can we do to help prevent further plaque formation in your coronary arteries? And if there's not, it can be fairly reassuring for people that if your calcium score is 0, it means your risk of a subsequent cardiovascular event of the next 5 or 7 years is low.
And what about for those people who might not have a coronary artery calcium score of 0?
So, look, the presence of any coronary calcium suggests that the process of atherosclerosis has started. And that is partly related to getting older, but it's partly related to risk factors and exposure to risk factors. And in particular, there's a wonderful piece of data that's come out from a longitudinal study called the CARDIA study, CARDIA, that's looked at the number of years of exposure to elevated LDL-C. And it's shown that in actual fact, the people who have a high exposure to LDL-C in the younger time of their life will go on to develop coronary artery calcium earlier. But for people who do have an elevated coronary artery calcium, and the important number seems to be 100, if you have a calcium score of 100, there's a 10 times increased relative risk of a cardiovascular event. And in these situations, it's important to think about what can we do to optimize cardiovascular risk factors. So which of the cardiovascular risk factors can we address? What are the residual risk factors that need addressing? Do we have to think about cholesterol-lowering therapy? And that may be with medication or with lifestyle and diet. Do we need to treat blood pressure? Do we need to look at inflammation? Will patients with calcium scores greater than 100 benefit from being on standard treatments such as statins? We also know that coronary artery calcium scores that are very high, over 1,000, are very high risk. And these people need to be evaluated carefully for any disruption of blood supply and need fairly intense management of both lifestyle and dietary factors to keep them from having a cardiovascular event.
And just on one of the points that you mentioned then and earlier about inflammation. So you said that we're now kind of starting to understand the role that inflammation might play. Can you delve into that for us, please?
So about 10 years ago, there was a trial that looked at using statin drugs in people with normal cholesterol levels, but high levels of inflammation. And it showed a reduction in cardiovascular events. But inflammation, having an understanding about the biology of atherosclerosis, we know that around vulnerable plaques and in atherosclerotic plaques in people's coronary arteries, that there are lots of inflammatory cells. And these inflammatory cells can cause maladaptive remodeling of coronary atherosclerosis and put people at risk for having a myocardial infarction. There is a simple blood test that can be measured, and it's called high sensitivity CRP. Now, often that CRP is particularly elevated when someone has an acute bacterial infection. And so if someone has a pneumonia or a urine tract infection, that may be increased. But in the absence of infection, if your high sensitivity CRP is elevated, it may mean that there are high levels of inflammation in your body. And this can be due to a few different things, maybe a non-cardiac condition such as autoimmune disease or allergy. But if those are excluded, then it may be a marker that something that is going on in terms of either lifestyle, diet, and exercise is causing an elevated CRP. And this is a potential therapeutic target. There was a trial published a few years ago that looked at people after having a heart attack who had elevated CRP levels after a heart attack and were treated with a fairly potent intravenous anti-inflammatory drug that modulates the immune system. And it showed a significant reduction in subsequent heart attacks in that group that had a reduction in inflammation. Now, practically it's not possible to do that, and it's ridiculously too expensive. So my approach as a preventative cardiologist is to recommend that people that do have a cardiovascular event or have elevated CRP look very closely at their lifestyle and say, what am I doing that is possibly inflammatory? What do I need to change in my diet? Do I need to move to a more plant-based diet? Do I need to cut out the amount of animal protein in my diet? Do I need to change my exercise program? Do I need to deal with other factors in my life that are contributing, to stress? How can I manage that with things like meditation or yoga? So what are the factors that may be contributing to inflammation? And then, how can we reduce it? And I want to emphasize here that the things that make a difference are, lifestyle factors. There are some supplements that may be helpful in inflammation, and some of them include things like curcumin or omega-3. However, my strong feeling is that unless the lifestyle and dietary building blocks are in place, supplements are just supplements. They're not going to deal with the majority of the problem.
And just on treatment, obviously, you've got a lot of tools in your armory, Jason, being a cardiologist. Can we talk about statins, though, and how often you might prescribe those and whether there are side effects involved with those?
Excellent question. I think very topical at the moment, because I think every week there's something that comes out about statins and statin-related side effects and their actual effectiveness. Where statins really make a difference is in someone who is at high risk or has already had a clinical cardiovascular event. So someone who has already had a heart attack or needing a stent or had a stroke or has the presence of a significant burden of atherosclerosis with a high calcium score, a high burden of plaque, significant plaque in the carotid arteries. This is where statins really provide benefit. And this is one of the strongest relationships ever in cardiovascular medicine. So someone who's already had an event, by prescribing a statin, trying to get down to a lower LDL-C, you'll make a significant reduction in the risk of having a subsequent cardiovascular event. And I think it's not just about cholesterol lowering. Statins do have a role, their pleiotropic effect at stabilizing plaque and perhaps a mild anti-inflammatory effect. When people ask me about side effects, I think that some people do get statin-related side effects. The most common is muscle aches. Sometimes the use of ubiquinol as a form of coenzyme Q10 can sometimes ameliorate those side effects. For the most people, the statin-related muscle aches are dose-related, but for some people they can occur at lower doses. Some people do feel some brain fog. It's been shown now recently by a team at St Vincent's Hospital in Sydney by Catherine Samaras that statins do not cause dementia or cognitive impairment. In actual fact, the most common contributor is vascular disease, and statins treat vascular disease. In the people that have not had an event, so we're talking now in the primary prevention, there are a subgroup of people that will benefit from statins. These are people with higher burdens of coronary artery disease. So high calcium scores, often above 100, above 300, or people where lifestyle and dietary management of their lipids has not managed to bring it down to an appropriate preventative level. Then I think it is worth a discussion. So I know statins can get a bad rap in the media and on social media. And for many years, a lot of physicians and doctors were probably using them too liberally. We are now getting much clearer into which groups of people benefit from statins. And what I always tell patients, by going on a statin, if appropriate, it doesn't negate the need to do lifestyle and dietary management of your risk factors, because studies have shown that will only be complementary and better. Once again, you can't, out-medicate or out-supplement poor lifestyle and dietary habits.
Well, statins are a little bit of a double-edged sword. Look, they definitely do have an effect. That's the first thing. I know there's some people who are almost saying that they're the number one evil in life and they don't achieve anything. But with advanced coronary artery disease, they do appear to help. But my personal belief is that's primarily related to the anti-inflammatory effect of statins and not so much the cholesterol lowering effect, because the same effect of statins has not been repeated with other cholesterol lowering medications. So they have a whole host of effects. They're very anti-inflammatory. They even appear to assist with vitamin D levels, amazingly. So there's a whole host of effects there. And so the thing is that they then are somewhat detrimental to other tissues, particularly the muscle and neurological system, and also possibly the blood sugar system as well. So, there's cases of people, it's quite common that patients will become a bit more forgetful, or their cognitive function will go down a little bit on statins. And it's simply because you need the fats to line your neurons. It's what makes up myelin and so on. And so I believe it's as simple as that. And most likely the solution is to use lower doses and use them primarily as an anti-inflammatory rather than kind of manically chasing an ideal LDL of 1.8 or something like that. My practice would be more normal to use a very low dose. And so in patients that I have that have advanced coronary artery disease, they generally would be on them. If they've then gone 5 years and they're improving, then my plan would be to get them off them eventually. And so it's their biggest role is in that more acute stage after heart attacks. But they do have a plaque stabilizing effect. It's not 100% clear how long the effect is beneficial for, but let's say a few years after a heart attack, for instance. I think it's certainly not for primary prevention and certainly not at very high doses. So just to talk about the muscle part, so it's quite common to get myalgia or muscle pains on them, and a small amount of people will get a life-threatening condition called rhabdomyolysis, where the actual muscle cells start breaking down, and this has got to do with the enzymes that the statins block, the HMG-CoA reductase, and so on. And so I do think monitoring CK levels is a good idea, and asking patients regularly about muscle pains. And I think one of the things that probably I object to the most is people are often put on them without being told of these risks, which can be quite significant. And I think it's very important to inform people of these risks and allow them to make an informed decision about whether they want to be on them or not, rather than just railroading them onto, okay, we're going to get a bit of Lipitor going on you type idea. So yeah, they're a double-edged sword. They can be used in very severe and acute cases, but they don't replace a holistic protocol.
You brought up a really good point earlier about endothelial dysfunction and inflammation, so that combination. Can you talk me through endothelial dysfunction?
Endothelial dysfunction is very much related to a compound called nitric oxide. Nitric oxide is very, very interesting. It's a compound that dilates the blood vessels or relaxes the blood vessels. So if you've got enough nitric oxide, you tend not to get high blood pressure so much, and you tend not to, if you're a male, you tend not to get erectile problems as much. And of course, then you tend not to get problems with ischemic heart disease. So if nitric oxide is compromised, and that can be compromised by a whole host of factors. It can be related to methylation, it can be related to environmental toxins, it can be related to genetic polymorphisms. So if your nitric oxide is compromised, then the ability of the arteries to be able to maintain a healthy state is compromised, and the chance of them becoming inflamed is much higher.
And that endothelial layer, it has metabolic functions.
Yeah, it's a metabolic tissue. You could say, yes, it is very important. And if your endothelial layer is not working well, basically your cardiovascular system is not working well. It's very, very linked to the overall function of the cardiovascular system. And so the nitric oxide piece is very important. The role of insulin is also very, very important. So if you are developing insulin resistance for whatever reason, I mean, the most common is just simple dietary mistakes, over consuming sugar and so on. If you are developing insulin resistance, then basically that's another cause of inflammation of the endothelial lining of the blood vessels. So those kind of factors, depleted nitric oxide and insulin resistance, appear to be two of the strongest predictors as to whether you're going to get endothelial dysfunction, and therefore you're at risk of developing inflammation of the endothelial lining, which is what I believe and many other researchers believe is the initiation of ischemic heart disease.
So when we were talking earlier about inflammation, obviously things like diet can be inflammatory. The fact that you're obese is inflammatory. If you've got insulin resistance, it's inflammatory. What are some other things that can contribute to the inflammation that can be detrimental to the development of atherosclerosis and ischemic heart disease?
Yeah, so if you're in a vitamin D deficient state, that's also considered to be an inflammatory state. And it's often related to chronic inflammation, and there may be a shift towards 125 hydroxyvitamin D with lower 25 hydroxyvitamin D. The story with vitamin D seems to be getting more and more complicated and deep, but the simple side of it is, basically you want to get people's vitamin D well above the 100 nanomoles per liter mark, generally speaking. Often we're looking at the range 125 to 150 as being optimal nanomoles per liter. And you also want to look at giving them something for the vitamin D receptor if they've been shown to have vitamin D receptor polymorphisms, such as the sulforaphane and so on. So you want to give it, but you also want to make sure that it's being received properly. So the vitamin D is very important, and you want to also think of the other fat-soluble vitamins at the same time. You want to consider giving K and also looking at the vitamin A levels at the same time. So and trying to get at least some of your vitamin D from sunlight is recommended, because that gives you sulfated vitamin D, which appears to be the most beneficial. So the second one is impaired methylation. So if you have high homocysteine, homocysteine is also inflammatory to the cardiovascular system. So that can be related to what we call polymorphisms around methylation, and it also can just be related to toxicity, I found. And many people who have extremely high homocysteine, I found they actually have mercury toxicity.
Okay.
So what's happening is that the environmental toxin is taking away or downgrading their methylation. So it's not always that the person's got a big gene mutation. And so I generally recommend looking at all the genes in concert and not just focusing on MTHFR. I do believe that's been overemphasized through the years. And I don't believe in this idea of check the MTHFR, then give folate. I think that's very simplistic. So probably better testing is to looking at a plasma methylation profile. That would be quite beneficial in some cases if you're looking at methylation being a problem. But the standard things would just be also testing B12, folic acid, and B6, and thinking about supplementing with those in the first instance, plus or minus TMG. They're all very helpful, plus or minus SAMI.
And some other things that can contribute towards that inflammation too, obviously leaky gut, infections, things like that.
Yes, those two things are very important, I would agree. And the majority of unwell patients will have leaky gut, also known as intestinal hyperpermeability. And it's really just related to, all types of inflammation. Now, particularly if you've got localized gastrointestinal problems, so if you've got severe dysbiosis or infections, that's going to lead to leaky gut. If you've got a generalized inflammation problem, whether it be related to environmental toxins or other causes, that will often cause leaky gut. So I would agree that's very important, and to think of that in any patient who's chronically unwell in some way. Chronic infections are also extremely important. And I'm glad you brought that one up. I mean, there was quite a bit of interest at looking at chlamydia pneumoniae infection and coronary heart disease a few years back, and it was found that there was an association between the two. However, the treatment wasn't found to be effective, particularly. However, Sometimes the problem has been that in these trials and so on, the treatment hasn't been given for long enough. And I actually suspect there is a causative role for infections, such as chlamydia and mycoplasma infections. So, if you do test for those and you find them to be positive, you can just do serology testing, and there is more advanced testing, such as spot testing, available in certain labs overseas. And if you find that, especially if someone's had a history of pneumonia and also plus or minus chronic fatigue, it's quite possible they've got a mycoplasma or chlamydia infection there. And by looking at then managing those with herbs and or antibiotics and or other strategies, I believe that can greatly help in reducing the inflammation in the cardiovascular system.
Many of the risk factors for ischemic heart disease are the same for vascular dementia and Alzheimer's disease. Dr. Michael Osiecki says it's so complex, yet so simple.
Obviously, without proper blood flow, you get organ, tissue, and cellular failure. So when we're sort of talking about cardiovascular disease, it's ultimately about something very, very chemical engineering. It's about pipe flow and pumps. At the end of the day, elasticity of the blood vessels, and then just failures in the heart and all the fallout diseases from it and causative issues that just affect the flow of blood throughout your body. So vascular dementia is basically damage to the blood vessels from multiple issues that then result in some sort of neurodegenerative outcome.
And that's a good way of a kind of a simple way of understanding it, isn't it? And there are so many things that can cause that impact to blood flow. What are some of those?
So starting off with a blockage, so a stroke. And we could talk about many different ways of that. Could be just a clot, that's what traditionally thinking, and probably what a lot of it we discussed about in this podcast is, a clot forming or atherosclerotic plaque. But another interesting one, much more related to what we generally think about dementia and Alzheimer's, is there is the whole amyloidosis of the vasculature as well, because a lot of amyloid plaques are formed near blood vessels and associated with the blood-brain barrier. And what could actually happen is these plaques can deposit in the blood vessels themselves and impede flow. Or, because there's many different shapes and polymerization of the beta amyloid oligomers to even form spindles and can pierce the blood vessels, which sort of introduces the next sort of issue with blood flow is damage to the blood vessels causing a bleed. So damage to the blood vessel and the blood vessels breaking, or the capillaries or breaking apart and causing a bleed, putting pressure onto the brain tissue, causing damage that way, and hypoxia downstream from that bleed. A lot of the damage is related to hypoxia. Basically, a lack of nutrients, a lack of oxygen going to the brain area where, talking about clots earlier, that's stopping it downstream of where that clot is happening, causing basically hypoxic events and an eventual cell death, swelling of the neuronal cells, loss of the ionic gap, and so therefore you lose membrane potential, so the neuronals stop working and eventually die off. And that's not real, I wouldn't say permanent, but it takes decades to repair that loss. And generally what ends up happening in the brain with new research is that it finds a different way of that damaged space. I guess the final one that I talked about earlier is that hypo event, so the low blood pressure side. A lot of the other ones are due to high blood pressure, tachycardia and stuff. This is more about low blood pressure, causing, once again, hypoxia in the brain. And this is a little bit more nefarious and a little bit more checks the general progression of what you typically say at Alzheimer's or Parkinson's or Lewy body dementia, which is a much more gradual decline, maybe a straight line, maybe parabolic, and declines, worse later on. Whereas vascular dementia is very stepwise. You have a big stroke, a big bleed, it has a massive step down in the in your cognitive function of wherever that clock happens to be. Most of the time in your cortex area, the top, brain. So generally, you use that higher cognitive function. But generally, you sort of first sort of see more like judgment and processing go first before memory in vascular dementia in a stepwise manner, where these low blood flow events, which are a little bit more difficult, are kind of slow, like there's small steps happening, which is looks a little bit more like a gradual decline.
So you're saying that someone who has Alzheimer's disease or developing Alzheimer's disease can be concurrently developing vascular dementia?
You look at the risk factors for cardiovascular disease and Alzheimer's, huge overlap. Diabetes is the major one. But, you look at Alzheimer's, and one of the few genetic risk factors is ApoE4, which is both involved in atherosclerosis and in Alzheimer's, because it's used for fat transport, mostly in immunal cells, and leads to fat deposits and fat buildup in the brain, and leads to the insulin resistance and immune dysfunction that we see in the brain with Alzheimer's situations. So there's a sort of huge overlap between the diseases just through risk factors alone. But probably one of the big things when I'm like researching a lot of new topics or whatever is I'll use an engineering term, doing root cause analysis, because, we've spent close to a century now looking at beta amyloid plaque and tau proteins, multiple clinical trials trying to remove them, decrease the function, whatever, doesn't work. And the question is kind of like going, well, as an engineer, as a biologist, like going, well, what's the normal function of like something like beta amyloid? What's the normal function of tau, which is the microtubule protein? So it's this breakdown of microtubules, and then thinking about, well, what will cause this to dysfunction? And what you quickly learn is something like beta amyloid it's a perfect example of hormesis in regards to low concentration has actually this big beneficial effect, whereas high concentration has this massive detrimental effect. It starts aggregating. These soluble oligomers are also quite toxic in itself. But if you go back and look at, evolutionary biology, this beta amyloid is a highly conserved protein or peptide in vertebrates. From Hydra to us, produces this protein. And because we discovered this protein associated with a disease, so it's always got this sort of negative spin on it. The Alzheimer's protein, that sort of thing is associated, and it's always associated with causing Alzheimer's disease, opposed to going, why do we have this protein? What is its function? And the function is at these low concentrations, neurogenerative, angiogenic. It helps vascular growth, helps maintain the blood-brain barrier, helps us, it's a temporary plug. And then also some of the more interesting things when you sort of talk about some of the lower life forms, it's a chelator. And that's why a lot of heavy metals are associated with Alzheimer's disease, is it's chelating all these heavy metal ions that causing oxidative stress and then aggregating around it. Viruses, HSV is widely associated with beta amyloid plaques, bacteria as well. It's a stress response and helps initiate the repair mechanism. The problem is overexpression leads to all these problems of it. It itself is toxic, i.e. it's toxic because it's aggregating around other life forms trying to kill it and defend the other life form. It's, a defense mechanism for these single cells to helping support repair. And then when it aggregates together, obviously it forms these big plaques that then get glycosylated, and that's when it really slings. And when it starts to bind to the tau protein, that's when you really start kicking into like that Alzheimer's thing. But we see that in vascular dementia because that disruption to the blood-brain barrier is actually a very key initiating event for future progression to Alzheimer's disease. And we see this sort of overlap between the two diseases, which generally accelerates the mental decline if you have both of that, had a stroke, as well as start showing signs of the Alzheimer's-based symptomology.
But at what point and what did cause the levels of the amyloid beta to increase and become detrimental? So that's when the risk factors come in?
Pretty much. And I guess a big event as well, progression of disease states, causing that inflammation or damage to the blood-brain barrier, causing that immune disruption, that activation of the glucagon synthase kinase 3, the GSK3, in its role in sort of that insulin sensitivity and decreasing that insulin sensitivity in the brain, in neuronal cells in itself, causing sort of major issues. It's kind of like when we're talking about cardiovascular disease, it's just basically hypoxia, poor blood flow is the initiating cause, so that, we see beta amyloid is produced in hypoxia and induces HIF-1 alpha. So at that low level, it starts producing to help, protect the cell. It's a stress response. It looks to me like a stress protein. And it's actually quite a shame because there's not as much research on its actual biological role. I'm reading Nature Review articles from 2020 and going, we actually don't know a lot about the biological role of these proteins. I'm talking a lot about beta amyloid plaque, which, is probably, I wouldn't really call it's the snowballing factor. It's a big prognostic marker to separate it from other ones. But tau, which is your microtubule protein, is a big factor. But the reason why that's being broken down is because you're not having autophagy, which is once again a mitochondrial thing, which is once again an oxygenation issue due to cardiovascular things. So when you start having these comorbid conditions or also start showing these other forms of dementia, it makes it a lot more trickier in terms of treatment, because you need to understand, well, what sort of the root causes? Is there a toxic onslaught, be it chemical or an infection? And do I need to clear that? There's obviously that big inflammatory, side to everything. And then because of that, you have mitochondrial issues and mitochondrial energy and that metabolic and type 3 diabetes that we talk about. And then that leads to the microtubule problem. We don't see that microtubules being broken down, forming those spindles, start piercing the membranes. And blood flow is so important because not only the blood oxygen supply, but also the lymph clearance, because that's that washing of the cerebral spinal fluid, especially during sleep, is so very important. If you're not sleeping well, you're not getting that good clearance of the beta amyloid plaques and things like that, that then drives towards snowballing what's already going on.
I know as practitioners we understand mitochondria and mitochondrial dysfunction, but do you think we overlook it, particularly in cases like this?
I feel like a bit like a broken record sometimes when I speak, because I always sort of bring up like some sort of aspect of autophagy and mitochondria, but that's because it's so important, because without autophagy, the cell goes into senescence, and it's sort of a stress response for the cell to maintain some resemblance of its function in the tissue, but it starts going into the state of inflammation to try and say, hey, immune system, clear me out. I'm broken. I don't have enough energy to apoptose, because what ends up happening eventually, that cell ends up necrosing, and that's bad. You get all these necrosing factors released to the body and causes further damage. So I feel like a little bit of a broken record, but it's always in the back of your head, because you look at the risk factors, diabetes, there's mitochondrial dysfunctions going on because of the glucose and that sort of thing. So yeah, I think it's a sort of fundamental thing. And it's not just CoQ10, the carnitines and even the phospholipids themselves, the sort of like, has a dual role. And there is some clinical evidence around the carnitines, acetyl-L-carnitine and carnitine itself, having some positive effect of cognitive function in Alzheimer's patients as well as supporting that mitochondrial function, as well as some good evidence in that metabolic side, which is probably why it also helps the Alzheimer's patients, to the brain insulin resistance involved.
What would be your kind of go-tos from the evidence as far as like supplementation and lifestyle are concerned?
Once again, the boring stuff, the omega-3s, but it's really about the EPA. Even I know studies have shown in Alzheimer's patients that they have low DHA. I'm at the opinion now that really it's about supplemental EPA. EPA goes to DHA. So it gives the body the opportunity to convert it over. There's all the studies in the Alzheimic dementia space have been all high DHA and haven't showed a very strong effect. We've also seen that as well in other cognitive studies. DHA supplementation does not equal to cognitive improvement, even though it's so high in the brain.
Yeah.
We see EPA having a beneficial effect. There's not as many studies, but there are studies in Alzheimer's patients that show EPA supplementation has improvement in cognitive measures.
Mm-hmm.
And then also in general, we've seen in elderly patient general cognition sales, it's EPA. Same in cardiovascular health. I guess the ester-based omega-3s, I forgot the drug name that they've called it. But once again, it's high dose EPA, 2, 3, 4 grams of EPA almost is the more important side, and a lower DHA. I am just coming less and less convinced around supplemental DHA outside of dietary sources, because I know certain fish have higher DHA than EPA, but it's really about the EPA in terms of supplementation because of its anti-inflammatory effect, and it's lower down in the cascade when you think about the endocannabinoid systems, the PPARs and all fatty acid signaling. It's lower down. So I sort of follow this hypothesis of lower down is kind of better than the higher ups, directly supplementing. It comes a little bit more like a drug sort of scenario of you're giving this high input of something that's very much going to this pathway only, whereas something at high dose or something further up in the stream can work in multiple pathways and has a supportive effect. So EPA is quite good in that factor in both vascular health and in the dementia side. Citrulline more than arginine in terms of the nitric oxide story, just sort of going even into the renal side a little bit, if they got renal damage as well, low protein, 100% for somebody with low renal function is very, very necessary. Once you're on dialysis, everything changes because you're getting stripped out every 2 days. But certain proteins are very much needed around it, especially the arginine, citrulline, tryptophan, histidine, taurine. Taurine is fantastic because it's both blood pressure as well as heart rate reducing, sort of can be broken down, metabolized like the homotaurine. Some interesting clinical trials of homotaurine high in a particular seaweed, I can't recall the particular species, is high in homotaurine, but you also get some conversion in your gut flora, and taurine itself has similar things. Because it's slightly GABAergic, it actually reacts with the GABA receptor. There's some interesting clinical trials, especially on the ApoE4 positive or heterozygous, even homozygous, which is about 20%, I think, of Alzheimer's patients. 10 to 20% of Alzheimer's patients have the ApoE4 gene defect. And it looks like in the phase 3 clinical trial a little while back, it was most effective in that. It wasn't universally effective, but there were subgroups where it was effective in it, homotaurine. The taurine itself is also very, very interesting in cardiovascular health.
While Dr. Osiecki recommends a Mediterranean diet, both Dr. Gupta and Dr. Kaplan mostly recommend a plant-based eating approach.
Now, when we're talking about a dietary pattern to recommend to someone with ischemic heart disease or coronary atherosclerosis, we have to think, what is the available evidence, not just in terms of reducing the risk factors that will lead up to the development of atherosclerosis. So this includes a dietary pattern that will lower blood pressure, that will lower atherogenic lipoproteins, lower LDL-C, lower CRP, cause weight loss, reduce the chance of developing insulin resistance and type 2 diabetes. And For the most part, the dietary pattern that has shown over and over is a mostly plant-centered Mediterranean-style diet. At the moment, and I know you've mentioned low carbohydrate diet and the ketogenic diet, but as yet, they may improve some of those parameters, but they also have not been shown yet to translate to a reduction in outcomes. So what we're interested in is we want to reduce the risk factors or some of the available biomarkers, but also after following a dietary pattern, we want to make sure that 5 or 10 years down the track, that dietary pattern has been associated with a reduction in cardiovascular events. And the only dietary patterns that have been shown to do that are, the more, Mediterranean-style diets, mostly plant-based eating, and the ketogenic diets have yet to be able to do that. So when someone comes in with established atherosclerosis, my suggestion is for them to look at some of the work of Dean Ornish, who showed that people adopting mostly plant-based vegetarian diet actually halted the progression of atherosclerosis, or some of the work of Dr. Michael Greger, who wrote a wonderful book called How Not to Die, and he's a very strong advocate for almost an exclusively plant-based diet. These are the sort of dietary patterns that I recommend. For most, what the other really important thing is, for the majority of patients, even getting 70 or 80% there is a significant improvement compared to where they were, where the majority of the population are. But for most people, a mostly plant-based Mediterranean-style diet with fish a few times a week is a healthy heart diet with plenty of healthy carbohydrates, whole grains, fruit and vegetables. What I find difficult about some form of low carbohydrate diet or the ketogenic diet is they actually exclude whole groups of foods that are known to be healthy and known to cause a reduction in cardiovascular events, such as fruit and vegetables and legumes. When you look at, some of the world's longest living people, and there's a great book called The Blue Zones by Dan Buettner that looks at which populations have the highest octogenarians and people in their 90s, even people in their hundreds, they all have diets high in legumes and whole grains.
Yeah, I've read that book. I really enjoy it.
And none of those groups of people have a ketogenic or low carbohydrate diet.
No, and in fact, I found it interesting because they're having white bread, but it's like locally made. They're drinking their one glass of wine at night sometimes, but it's locally produced red wine. But they have a lot more exercise, and they don't have stress, and they have community. So there's a lot of
That's right. And the wine that they have, it's locally made. It's high in resveratrol, which is in red wine, but it seems to be a much higher antioxidant level.
And I think the concept as well, Jason, of community and that social connection is a huge thing.
Absolutely. They eat together. They have multi-generational homes. People eat as families. And I think that's so important. And in our busy lives, Tony, it's not something we tend to do all that often.
In the next episode of Between Clinical Minds, we discuss kidney disease with Henry Osiecki and renal specialist Dr. Patana from Thailand. Thank you for listening. We hope this podcast engaged and empowered you. And thank you to all of our experts. You can read more information on each of them on our website, bioconceptsengage.com.au. If you enjoyed this episode of Between Clinical Minds, please refer a friend and share the love. To continue the conversation, you can contact us at bioconceptsengage.com.au, where community is more than a concept.